Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information. This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Welcome to Navigating the HER2 Spectrum in Breast Cancer, Evolving Diagnostic Paradigms for Clinical Excellence, a program supported by Medscape Global Oncology. My name is Sarah Tlaney. I'm Chief of the Division of Breast Oncology at Dana-Farber Cancer Institute. And joining me today are my very two esteemed colleagues, Dr. Frédéric Pinault-Yorca, Professor of Pathology at Jean Perrin Comprehensive Cancer Center in France, and Dr. Giuseppe Corigliano, Professor of Medical Oncology at the University of Milan in Italy. Welcome, and thank you so much for joining today. Today, we're going to be covering the need for evolved HER2 testing, the evolving HER2 spectrum, determining HER2 status, heterogeneity, and guidelines, and we'll put this into perspective with clinical applications in a patient case. So let's start with our first topic, which is a need for evolved HER2 testing. So why is HER2 testing so important? We certainly know that it has been critical to help us guide treatment selection. And with the evolution of HER2 targeted agents, this has also evolved. So, Giuseppe, would you mind giving us an overview of the latest data and therapies that are used based on HER2 status?
Yes, absolutely. HER2 disease, of course, actually cannot be categorized as HER2 positive and HER2 negative. There is actually a spectrum of expression of HER2. And if we connect this with the clinical data, in the Destiny 4, trastuzumab deruxtecan was tested in the HER2 low disease that can be defined immunohistochemical 1 plus and 2 plus with FISH non-amplified. But in the Destiny 6, what we did is to test the activity of trastuzumab deruxtecan in patients with HER2 ultra-low, that is any staining more than 0% and less than 10%. If we remember, the first prospective randomized trial to test the activity of a next-generation ADC, like trastuzumab deruxtecan in HER2 low disease, was the Destiny Breast 04 prospective randomized trial, including patients with immunohistochemical 1 plus, 2 plus, and FISH non-amplified, in patients who never received no more than 2 lines of chemotherapy, even if we know very well that these patients received more than 2 lines of chemotherapy. Originally, the study was designed for HR-positive disease, but we know perfectly that there was a small cohort of HR-negative. Patients have been randomized to trastuzumab deruxtecan, 5.4 milligram per kilo every 3 weeks, versus investigator choice chemotherapy. And the primary endpoint was median progression-free survival in HR-positive patients by blinded independent central review. The secondary endpoint was overall survival in HR-positive and median PFS in all patients, including also the HR-negative. If we check the results of this study with a median follow-up of more than 3 years, the use of trastuzumab deruxtecan improved median overall survival from 16 months in the standard of care arm to 22.9 months in the trastuzumab deruxtecan arm with the hazard ratio of 0.69. If we move to the data of Destiny 4 according to HR status, With 36 months of follow-up, still we have a benefit in HR positive population from 17 months to 23.9 months, but also in the HR negative cohort, there was an improvement in median overall survival from 8 months to 17 months with a NADSA ratio of 0.58. Checking, of course, the Destiny 4 overall survival by investigator best response, is very clear that, of course, the patients who achieved a very good response had also a better outcome. So in those in which there was a complete response, of course, benefit was much more than in those with stable disease and partial response. What's about safety profile? The most common toxicity was, of course, nausea and vomiting, hematological toxicity. If we check, of course, the activity in the other study that was the Destiny 6, this was a completely different study. Patients never received chemotherapy. They have been treated 1 or 2 lines of endocrine therapy, including CDK4/6 inhibitor. And there was a small cohort of patients who received 1 line of endocrine therapy for the metastatic setting, but progressing within 60 months after exposure to CDK4/6 inhibitors. Patients with HER2 low and ultra low disease have been randomized to trastuzumab deruxtecan versus investigator choice chemotherapy. And patients have been treated with HER2 low, 1 plus and 2 plus with FISH non-amplified, or HER2 ultra low, any staining more than 0 and less than 10%. In the analysis that has been published on New England Journal of Medicine, the median progression-free survival in HER2 low disease improved from 8 months to 13.2 months. Progression-free survival in intent to treat population had similar data with improvement of median PFS from 8 months to 13 months. When evaluating the activity in HER2 ultra-low disease, median PFS improved from 8.3 months to 13.2 months with the NADSA ratio of 0.78. The antitumor activity was impressive. Overall response rate in intent to treat population was 57.3% versus only 31% with standard chemotherapy arm. And when checking overall response rate in HER2 ultra-low, there was an unprecedented 61% versus 26% with standard chemotherapy. The safety profile in the Destiny 6 was very similar to the Destiny 4, nausea and vomiting, hematological toxicity, and finally ILD, very few cases with the grade 5 ILD. So we have to remember, of course, that some translational studies have been performed, and maybe our chairman can comment on this.
Oh, thank you, Giuseppe. That was a fabulous overview and clearly does show that TDXD should be standard of care for patients who have HER2 low or ultra low metastatic ER-positive breast cancer. But I think it has left us with this question about what to do with patients who are not eligible. So what about those patients who are truly HER2 null? And we've seen a little bit of data from the DAISY trial where we had looked at patients who were treated with TDXD really irrespective of HER2 status. So they had a cohort for patients who are IHC0, 1 plus, 2 plus, and 3 plus. And what we did see was that the efficacy does increase as HER2 staining increases. But within the IHC0 category, that did encompass patients both who were null and ultra low. And we did see robust efficacy even within that group. And so it has left us trying to understand, could the nulls really be benefiting? And so there is a study that is ongoing, Destiny Breast 15, which actually does have cohorts of patients who are HER2 IHC0, both with ER positive as well as a separate cohort with ER negative disease. And then they will centrally test to be able to figure out who's null versus ultra low and be able to explore efficacy within that trial. And so hopefully we will get more data to hopefully clarify if some of the null patients could actually benefit from the use of TDXD. But at this point, this does remain an open question. There are also other HER2-directed ADCs that are in development, and we've actually seen a lot of data now to date with SHR A1811, also known as trastuzumab rezetecan. We saw data actually at ESMO that was a randomized phase 3 study comparing trastuzumab rezetecan to capecitabine paratinib, where we saw actually a very impressive difference in progression-free survival, with the PFS for SHR A1811 being around 30 months. So exactly what we've seen with TDXD in the Destiny Breast 03 trial. It also is a HER2-directed ADC with a topo-1 payload with a very high drug-to-antibody ratio, and does seem to have less in the way of interstitial lung disease. We saw an ILD rate of around 2% within that trial. And so I think this ADC also looks very robust, but also looks kind of like TDXD in terms of efficacy. There are also lots of other HER2 directed ADCs and targeted agents in development. And so I think this space continues to evolve. But it does leave us with the question of how to really test for HER2 and what the optimal way is to use HER2 as a way to help us make treatment decisions. And so no one better than to walk us through this than Frederic, who can really help us understand the continuum of HER2 expression and how to think about this in our current practices.
Thank you, Sarah. Yes, of course. In fact, we have been working with HER2 from a very long time, and it has been really central to breast cancer classification and treatment selection. And historically, we were using HER2 testing in a binary way, identifying tumors with HER2 overexpression or HER2 gene amplification that could benefit from HER2 directed therapies such as trastuzumab versus the other tumors. But as Giuseppe showed us, the therapeutic landscape has changed a lot with the development of ADCs, particularly with the trastuzumab deruxtecan, but not only. And these agents have demonstrated meaningful activity in tumors without the classical HER2 overexpression, revealing that low levels of HER2 protein expression can be therapeutically actionable. So, as a result, HER2 is now best understood as a biologic continuum of expression rather than a strict positive or negative state. And this evolution has profound implication for testing, reporting, and clinical decision making. So, based on the current evidence and clinical trial definition, HER2 expression in breast cancer spans several categories. So don't forget, and we still really need the HER2 positive, so the 3 plus and the 2 plus with HER2 amplification by in situ hybridization. The HER2 low with the immunohistochemistry 2 plus without amplification and the immunohistochemistry 1 plus. Then we have the ultra low that could also be referred as immunohistochemistry 0 plus or 0 with membrane staining. And here we have the immunohistochemistry score with faint, incomplete membrane staining that is present in more than 0 up to 10% of tumor cells. And then we have the HER2 null. So it's really the immunohistochemistry 0 without any detectable membrane staining. It is really important to emphasize that ASCO CAP guidelines do not formalize HER2 low or HER2 ultra low as diagnostic categories. Instead, they recommend a clear reporting of discrete immunohistochemistry scores accompanied by interpretive comments that reflect current clinical relevance. So the distinction between immunohistochemistry 0 with or and without membrane staining that was previously considered clinically irrelevant is now also significant along with the 1 plus and the 2 plus non-amplified, particularly in the metastatic setting. So let's go now through the evolution of the different guidelines from 2007 to 2023. The earlier guidelines starting 2007, 2013 from ASCO-CAP really focused on reducing false positive and false negative. So they redefine immunohistochemistry threshold and in situ hybridization interpretation. In 2018, we had big changes. First of all, they clarified the 2 plus, or also called the equivocal, because for a moment, 2 plus was considered with complete and incomplete membrane staining with moderate intensity. And they really only consider 2 plus the cases with complete and moderate membrane staining. They introduced normal in situ hybridization group classifications that were a little difficult for us to recognize, and they reinforced reflex testing and second observer review. In 2023, the ASCO-CAP guidelines update was really a refinement, not a redefinition, as I said before. In fact, they reaffirmed in 2023 the 2018 recommendation, concluding that available evidence did not justify redefining HER2 positivity or creating new immunohistochemistry categories. And however, in those updates, they introduce best practice guidance that acknowledges current therapeutic realities, and that was what we were expecting. They emphasize distinguishing immunohistochemistry 0 from 1 plus, because we knew that many cases that were classified as 0 were in fact 1 plus. They recommend 4x magnification for assessing the faint membrane staining. They encourage second pathologist review for cases near the 10% threshold. And they advise the inclusion of interpretive comments regarding potential treatment relevance for low level of HER2 expression. Thus, while testing algorithm remained unchanged, the clinical interpretation of results has evolved in these 2023 guidelines. But we have, for clinical practice, and also for the dialogue between oncologists and pathologists, we have to take into account something that is very important, is HER2 heterogeneity. We know now that we have a temporal heterogeneity because we have longitudinal studies comparing primary and metastatic tumors that demonstrate that HER2 expression is dynamic. And we have approximately 15% of tumors that shift from HER2 immunohistochemistry 0 to HER2 low, and almost the same percentage of tumor, 14 to 15%, from HER2 low to HER2 0. And those changes are more frequent in hormone receptor positive disease. That is the disease that we are really looking at for those low levels of HER2 expression. So they really underscore the importance of HER2 retesting at recurrence or metastasis in alignment with guidelines recommendation. But we have also spatial heterogeneity. And we know now from autopsy and multi-site biopsy studies that immunohistochemistry 0 and HER2 low lesions can coexist within the same patient. And the variability can be seen between organs or within a single lesion. And we have different patterns of heterogeneity that can be found with clustered heterogeneity, where we have clusters of HER2 positive, clearly sometimes amplified clusters with non-amplified clusters. And we have also scattered pattern of expression of amplified cells and mosaic patterns with different level of expression. So these patterns challenge the assumption that a single biopsy reflects global tumor biology. So, having said that, what are the best practices today for HER2 assessment in routine practice? Today, immunohistochemistry remains the preferred initial test. It requires a validated assay, if possible, the Ventana 4B5 assay that has been validated in the clinical trials with trastuzumab deruxtecan, especially in the HER2 low expression levels. Control spanning the low expression range, careful evaluation of membrane staining pattern, intensity, and percentage. For in situ hybridization, this is required for all the 2+ equivocal cases with strict adherence to the guidelines. And of course, the pre-analytical factors, the fixation, the tissue processing, the section thickness are really critical. So we really need to train the pathologist for this level of quality. We know that core needle biopsy may underrepresent heterogeneity, especially for the low level of expression. And the ASCO-CAP guidelines recommend retesting on excision specimens in selected cases, especially grade 3 tumors with negative core needle biopsy results. And in general, any case where we have an HER2 score 0 on a biopsy, even on a primary tumor sample if the patient is metastatic, to be sure that we don't miss an HER2 low expressor. We have now, and it was something that was published in 2025, we had reporting updates from the College of American Pathologists that we used worldwide. It was a major practical advance, and they were really separating from ASCO-CAP guidelines. So they separate immunohistochemistry 0, no staining, from immunohistochemistry 0 with membrane staining. So this is the HER2 null and the HER2 ultra low. They allow the inclusion of standardized explanatory comments defining HER2 low and HER2 ultra low as used in clinical trials, and they improve communication with the non-pathologist member of the multidisciplinary tumor board. So it was very important for the clinician to have the trigger words. Is it an ultra low? Is it a low? Or is it a positive HER2 case? This aligns reporting practice with contemporary therapeutic decision making without altering the diagnostic categories. So we see that immunohistochemistry is, and of course in situ hybridization, as considered today as the gold standards, but they are not fully satisfactory, especially in the low, for the low range of expression. So we have emerging diagnostic approach on tissue. We have quantitative and proteomic methods with mass spectrometry based proteomics that enables absolute HER2 quantification. They may improve the stratification at the ultra low end of expression. Currently, they can be considered as complementary too, but they are not replacement for immunohistochemistry, because the major limitation today is the cost that is extremely high and the absence of clinical validation. We have also artificial intelligence tool and quantitative, and one that has been developed in clinical trial, that is a quantitative continuous scoring system, the QCS. That's a computational pathology platform that analyzes a whole slide image. It provides continuous objective HER2 measurement, and studies have demonstrated improved prediction of response to trastuzumab deruxtecan compared with manual immunohistochemistry scoring. And there is also David Rim's team that has developed a high sensitive quantitative assay that is a quantitative immunofluorescent assay that reveal HER2 signal in many immunohistochemistry 0 tumors. It highlights, of course, the limitation of conventional immunohistochemistry and the limit of discrimination of our human eye at low expression level, because immunofluorescence is extremely sensitive. So this is very promising, but these technologies require further validation before routine clinical adoption. So, to finish, what are the guidelines integration across the different societies? So, as I said before, the ASCO CAP maintains the traditional HER2 categories, but emphasize refined reporting and best practice. The NCCN recommends biopsy and biomarker reassessment at metastatic diagnosis and incorporates HER2 status into evolving systemic therapy algorithm. And the ESMO living guidelines explicitly reference the HER2 spectrum and reinforce retesting to guide precision therapy. Together, all those guidelines support a dynamic reassessment based approach to HER2 testing. So, what would be my take home messages? HER2 is no longer binary, it's a therapeutically relevant continuum. Accurate discrimination of immunohistochemistry 0, 0 with membrane staining, and 1 plus matters. Heterogeneity is a temporal evolution, and temporal evolution necessitate retesting when the sample is negative. Clear standardized reporting supports optimal patients selection in clear words really understandable by the multidisciplinary tumor board. And emerging quantitative and artificial intelligence tools may further refine HER2 assessment in the near future. So HER2 directed therapies continue to expand beyond classical overexpression. The role of the pathologist and the precision of HER2 testing has never been more critical. By aligning methodology, reporting, and guideline interpretation, we can better translate biologic complexity into meaningful clinical benefit for the patients.
Oh, that was an incredible overview of thinking through the HER2 spectrum. So thank you so much, Frederic, for taking us through that. So I think given now that we are well equipped now to think through HER2 testing, we thought we'd put it into perspective with an actual patient case. So this is a case of a woman who presented with metastatic hormone receptor positive HER2 negative breast cancer. HER2 was IHC 0 at time of metastatic recurrence. The report did not specify whether the tumor was ultra low or null. It just reported IHC 0. The patient had progressed on endocrine therapy with the CDK4/6 inhibitor and then subsequently went on to receive endocrine therapy and a PI3 kinase inhibitor and then developed disease progression. And so now the patient's seeing you ready to start chemotherapy. And so you're faced with the conundrum of what you're going to do. So Giuseppe, you really led the DB06 study and help us think through the use of TDXD in this upfront setting. What would you do in this case, knowing her HER2 IHC was only reported as 0? How are you going to think through what to do for her?
So the first thing to do is to contact Frederic and to ask if the ASCO CAP was evaluated according to 2018 or 2023, because eventually I don't need another biopsy if the ASCO CAP is updated. So eventually, if Frederic will tell me no, is absolutely 0, there is no 0 plus, no expression, of course, what I'm going to do, or to rebiopsy, or eventually to get the old tissue sent to pathology, the primary tumor, because maybe having more tissue, you can get more opportunity to have an HER2 ultra low. So this is what I am going to do. I will do my best to have the right assessment of HER2 and to offer to the patient the opportunity to receive trastuzumab deruxtecan.
Oh, thanks, Giuseppe. So, Frederic, if you get these kind of requests where someone asks you to go back and look at the older tissue and make a decision about whether it's null or low, how do you feel about that? Do you ever feel like
Um,
you'd rather they rebiopsy, or how do you think through that?
First of all, I will go back to the slides because we know that, especially if it was not in my institution, the pathologists may not be really aware or interested in the HER2 low, ultra low categories, and we know that some up to 60% of the zero can be 1 plus, and some of them can also be ultra low. So we really need to retest those cases. That's very, very important. This was also shown in the DB06. So this is very important to go back simply to the slides. We did a study like that in our institution. It was an international study led by Beppe Viale, and we found that going back to cases that were like 5 to 10 years back, even in institution like us where we are supposed to follow the guidelines and to describe what we see, we classified 20% of cases in immunohistochemistry zero that were 1 plus. And of course, after that, we reviewed with the ultra low, and within the zero category, we had 40% of cases that were in fact ultra low. So it's extremely important to reassess with, maybe take a long time to go back to the slides because sometimes it can take 5, 10 minutes, but to be sure that you have this material. This is the first step to review the slide. And then to go back to a large sample if we have the primary tumor.
Yes, that's a good point. So I think we've gotten used to trusting an older sample, not really needing a current sample before initiation, particularly because this um, receptor is so dynamic and I think is challenging. And so I've usually felt comfortable if the pathologist tells me that actually that last biopsy was ultra low. And so, Giuseppe, let's say Frederic pulls that prior biopsy and tells you that in fact it was HER2 ultra low. How would you make a decision about whether or not you'd want to give TDXT or another chemotherapy agent in this upfront setting?
Well, this is a very challenging question and depends on the extent of disease or eventually if the patient is symptomatic or not. But if you have indication to chemotherapy and the patient is symptomatic and you believe you can derive benefit from a smart chemotherapy, I would give for sure trastuzumab deruxtecan because you have more activity in terms of response rate, a better median progression-free survival. So in a patient like this with visceral disease, my first option will be trastuzumab deruxtecan.
Well, it just goes to show how critical it is to really understand the HER2 status because it clearly would change what drugs are available for this patient. And so in this case was really important to get that information. This was really an incredible discussion and a wonderful overview of thinking through the spectrum of HER2 status. And it really does show how critical it is for us to understand this to be able to figure out which patients are appropriate candidates for TDXD. So thank you so much, Frederic. Thank you so much, Giuseppe, for the fabulous presentations and discussion. And thank you all for participating in this program. Please do continue to answer the questions that follow. Thank you.